Good morning. Thank you for the invitation. Thank you, Vincent, for accepting to take a gynecologist on this in your club of coloproctologists. I'm in charge of the maternity ward, not gynecology. So I just want to make this clear because if Séverine heard that, she might be upset. So this is something which is really at the crossroads of all the issues we've been discussing. There's obstetrics and then proctology. So complete perineal tear. As Vincent said, you should talk about what, when, how, and then. It's a broad topic that I only have 15 minutes, so it's going to be very, very quick on some topics, but I'll really try to focus on the most important stuff. Now, for a clinician, especially for us in maternity, there are challenges in terms of the diagnosis, in terms of the repair and the post-op care of those patients, and also we want to look at prevention in order to avoid these tears. And also there's a major challenge, which is the women who are going to be pregnant after obstetric anal sphincter injury. How are they going to choose to deliver their next babies? So I'm going to start with a definition. What is a complete perineal tear, as we call it? We talk about périnée complet, complete perineal tear in France, which is probably a misnomer because now the recommended word that we should use is OASIS, LOSA in French, obstetric anal sphincter injury. This is the reference, the term of reference. So it's a perineal tear which comes from fetus delivery, especially at the moment of the head deflection. It can also be during the passage of the posterior shoulder, and it can also be when forceps are used even before the fetus head comes out. And this tear actually impacts the anal sphincter. You have a classification which you know to categorize these tears. And when you look at the Royal College classification, which is also recognized by the WHO now, OASIS would be stages from 3A to 4. 3A, 3B depends on the damage to the sphincter, to the external sphincter. Now, a few epidemiological data about OASIS and tear in general. Perineal tear during delivery happens very frequently. It doesn't mean that there are bad practices. It can happen in up to 50% of deliveries. That's superficial tear, grades 1 or 2. There is a current decrease in the rate of episiotomy. If you look at France before 2012, you can see that we were lavish with episiotomy. It was more than 25% of patients. And it has decreased in 2016, and then in 2021, as you can see, 8% only. So that's probably thanks to the controversy very present in the media related to obstetrical violence. And I'm sure that this decreased episiotomy for the benefit of patients. In 2021, there was a perinatal survey which shows that there was only 8% episiotomy. OASIS in France, still based on the data from that survey, is about 1.1% in 2021 of deliveries, vaginal deliveries. Well, it was a little bit less than that in 2016. So is there a connection here between the decrease in episiotomy and the increase in OASIS? Well, I'll get back to that in a moment when I talk about instrument-assisted delivery, but I'm not sure that there's a link, actually. You will see that the prevalence rates are very low in France compared to what you see in the rest of Europe, where it's around 3%, and compared to what you have in the USA, which would be 6 to 7%. Now, for instrumental or forceps delivery, you see that it's an important risk of damage to the sphincter, with a prevalence which is about 20% of forceps deliveries. And then the link with episiotomy here seems to be a little bit clearer, because for some types of instruments, especially spatula, that's a very specific type of forceps, you see that there is a link between the episiotomy and the reduction of oasis risk. It's not so clear in Bertrand Gachon's study for forceps. His conclusion is that there is no significant difference, but it's probably not robust enough, even though the percentages are really different. Not so much difference, however, for the vacuum deliveries. Now, the factors are known. You have mother-related factors, like if the woman had a baby before, there is a certain number of factors linked to the delivery, like the use of instruments, a long expulsion phase, delivery. Maybe these are actually intermediate factors rather than risk factors. And then everything that has to do with the maneuvers, and also stuff related to the fetus, macrosomia, or occipital posterior presentation, if the fetus's head presents a higher diameter. So, diagnosis. We know that there is an underdiagnosis problem. We know that the experience of doctors and midwives plays a key role in the diagnosis of oasis. We also know that the training of healthcare professionals is going to improve the diagnosis. And when you look at literature, this is data from the IPIC survey coordinated by Abramovitz. Well, of course, in EPIC, it's a very specific population. You know EPIC, right? It's women who have had a forceps delivery or who have had oasis, and they are asymptomatic. And so they have had endoanal ultrasound, and among these women, you see that 49% of them has sphincter damage which had not been diagnosed, which was actually hidden. So there is a very high level of underdiagnosis. Probably it would be less than that if we had symptomatic women in the study. And if you look at other studies, you see that in the first child delivery women, you have about 30% of sphincter damage, which is only identified through ultrasound. So we do have an underdiagnosis problem. We do also have an overdiagnosis problem. I have a series here from Ireland, Fitzpatrick, in which you have 17% of actually normal sphincter on the endoanal ultrasound, while the diagnosis had been oasis. So compared, when you have this problem of under or over diagnosis, a lot of people ask the question of how relevant ultrasound is to identify these lacerations, and today we cannot actually answer this question. It would need to be assessed. But given how invasive this ultrasound is, I think that we should really need to think twice before we want to use it for just a regular vaginal delivery. What we do see is that it's really important to train healthcare professionals. This is going to improve the diagnosis. And also, when I was a student, there was a kind of criminalization of oasis. You know, when you had a delivery with sphincter damage, you had to go and see your boss, and it usually didn't go well. So probably at the time we used to underreport these tears just because the climate was terrifying in the hospitals, and I know it is still the case in some areas. And I'm sure that we need to improve that for the sake of our patients. plus the consequences of OASIS are important. You know, it's part of the maternal morbidity factors. I would plead to include that into the severe morbidity factors because of the complications, which you know, especially long-term complications, with numbers of fecal incontinence, long-term fecal incontinence, which is quite high. You see here in some studies you have 40 to 60% of women who have that. And also it has an impact on the quality of life. Now, how can we prevent these injuries? Well, I would say preventing this kind of damage, but the idea is to prevent fecal incontinence, and we know that we can also have fecal incontinence without OASIS. It's about 50% of fecal incontinence postpartum. We know that not everything has to do with a sphincter injury. During pregnancy, we have no information. We don't know what we could do to prevent that, except for maybe controlling the fetus weight gain. During the first phase of labor, we don't know what we could do. During the second phase of labor, in the latest guidelines of gynecologists, we have recommended perineal massage or hot water bottles, you know, but delayed push is a little bit more efficient. And also, what I would like to add, because it seems to make sense, rotation of posterior posture, you know, in order to reduce the diameter of fetal presentation. During delivery, manual control, of course, is important, because you see that you have a lot of tears which happen because there was no manual control, and also control of the push effort of the woman, being very careful when you use forceps or vacuum. You know, you need to remove the forceps before the fetus actually comes out. Episiotomy is not recommended to prevent OASIS. If there is episiotomy, it has to be done in the medial lateral angle with an angle of 60%. And of course, training to protect the women's perineum, training to perineal exploration and to sphincter repair. Now, some would also ask the question of C-section for all women. That would help prevent OASIS, probably. There is a study here from Sweden, which I'm sure you know. It's this study on a vast cohort, which shows that age is a major risk factor, and also the neonatal weight. And it also shows that women who have C-sections are not completely free from risk. And the role of the mother's age here is really important. So, of course, you would reduce the risk of sphincter tear with a C-section. But C-section is not just a benign intervention, even if it's been scheduled. And you always have to balance the short-term risk, which is probably low, even if you have a little bit more bleeding and infection and thrombotic complication. But the long-term risk is rare, but very serious, with potential severe hemorrhage, which can be related to the placenta insertion. Now, for repair, we are more in favor of immediate repair with an end-to-end technique that should be preferred, and additional post-op care. And then this last point here, for delivery after OASIS. Well, it's really very difficult to decide on this. There's no consensus. The position of the National College of Gynecologists is in favor of not a systematic C-section, only in case of functional sequela of grade 4 OASIS. There is no predictive model for the risk of sphincter tear in pregnant women that is robust. And the scientific literature both quantitatively and qualitatively, is very limited on this topic. There is only one randomized trial which was carried out on a very specific group of women, as I said, and which shows that C-section does not have a protective effect on the risk of fecal incontinence. The risk of recurrence is 1.9%. And there is a higher risk in literature in the prospective series. But so the problem of this trial is that is the cohort that was included. And it's a trial that gives us reassuring data, but it is not conclusive in terms of C-section having a protecting role, because the patients who are included in that cohort are all asymptomatic with very specific OASIS, as I said, hidden or unidentified lesions. And so the outcome that we were interested in would be to measure that when we know that the incontinence can actually arrive later, and it would be greater after 50. And of course, what we want to work is work on the long-term effect. Now, just a word of what we've been doing at Saint-Joseph. We're very lucky because we have a maternity ward right next door to the proctology ward. So we can have access to the great expertise and technical instruments. We can work and assess the anal sphincter function on patients who have had OASIS with ultrasound and manometry. These women, often they come from the maternity, but we also get patients from other maternities. We see them in obstetrics and proctology consultation. We look at the symptoms, and when you do that, we realize that we actually go way further than what would be done in the conventional post-delivery follow-up, because there's a taboo related to fecal incontinence. So I think it's really interesting to have these consultations. We try to assess the risk. We try to assess the risk to benefit ratio, because it's never vaginal delivery versus C-section. It's always attempted vaginal delivery versus C-section. Information is key, and also we'll listen to the patient's project in order to be able to make a decision together as to the delivery strategy. Another important element is ongoing training and initial training. In terms of initial training, we work with the midwife students and residents, and also ongoing training in which we integrate obstetrical mechanics, perineal anatomy, diagnosis criteria for OASIS, and repair and management workshops. So the take-home here is that when you talk about prevention, you talk about prevention of OASIS, but mostly prevention of fecal incontinence, because usually it's the same actions. It means that we have to obstetrically manage and control labor and fetus delivery. We need to look at the consequences of OASIS. We need to inform the patients. When you inform them, it always works better. Repair and management of postpartum. And also very important for us, training. About the choice of the path for delivery, I think you always have to think that when you decide on a delivery pathway, you don't think of only one outcome, and OASIS and incontinence are not the only two things that you want to think about. You have to integrate other parameters like morbidity, especially when you look at C-section. It's very important also to give the patient the choice. You need to hear what she has to say about her delivery project and to make sure that it matches our recommendations. And I think that we still need to think about a certain number of things. I think we should be able to conduct a trial. It's not easy, but we should really work on that. And then the last point, but that's more for epidemiologists who work on morbidity. OASIS should be included in the factors of severe maternal morbidity. We see that OASIS can have heavy consequences, and it should be considered in the morbidity factors. Thank you. Thank you for this beautiful presentation. We're going to take questions. It's not a question, but a comment. I'm here. In Marseille, we did a piece of work which we did not publish, but I think it's really important to say to the patients, well, because you see them at the beginning and you see them afterwards, but it's to avoid constipation. It's also something that we discuss with midwives and physiotherapists. You know, it's not politically correct because people are obsessed with a very tonic perineum and they are constipated and they're very happy because they have a great tonus, they do Pilates and yoga, and then 20 years later, let me speak, let me finish. And so prevention also means that you need to prevent constipation. You want to say that incontinence is one thing, but constipation is also important to be taken into account. I don't know if you mentioned that, if you see them at an early stage and then maybe you don't follow up on that. But while we work on immediate postpartum, we do work on constipation also. It's true that we are organized in such a way that after 4 or 6 months, they will see our colleagues from coloproctology, so we know that they are in good hands. But thank you for mentioning it, yes. The problem when people from the south of France ask questions is that their questions take so long. My question is sometimes when you see patients who come to us for OASIS, we can't see much because it's been very well repaired, and sphincter failure is usually due to stretching neuropathy, and this is not indicated as a C-section indication because we know that these patients are going to get worse because there's a cumulative effect. What do you think about that? Yes, I agree. As I said, OASIS is far from being the only reason for fecal incontinence or potential fecal incontinence that is going to happen in postpartum. So quantitatively, yes, stretching neuropathy is more frequent. Very often it's the same obstetrical mechanism, actually. It's stagnation during the last stage of labor and then a prolonged effort, pushing effort and forceps and the big babies, you know. So we see that. Here, as far as we are concerned, our attitude is that for patients who have normal sphincter, but with manometry identified insufficiency, we recommend C-section. And if the patient agrees, yes, that's what we do. What is the ideal age to minimize the risk? Now, this is a very complex question. Basically, whatever the pregnancy outcomes, it's always best for women to have a baby before 35 and to deliver their babies before the age of 25. But this doesn't mean much because you see that the age of first maternity that keeps on increasing, even including in France, and despite communication strategies from public health institutes, it doesn't change. So it keeps on growing. So we can only see that there is a link with the age of the mother, but there's not much we can do about it. It's true for OASIS, but it's true for all other complications like high blood pressure, the risk of complications or C-section, diabetes. Age is a risk factor in terms of deliveries and postpartum. So you say before 35. Well, when would what would the lower limit be? Well, it's difficult to find indications about that because, of course, we have more women who have babies after 35 than under 20, under the age of 20 in our big series. So it's hard to get information about that. Maternal morbidity is very rare, so we don't have enough statistical evidence. There is a level of risk in teenage pregnancies, of course, but as far as I know, OASIS does not come out as one of them, but maybe it's because we don't have enough information about that.